Only You, where we discuss mental health issues in a hopefully simple format for you. I ask the questions that I'm sure some of you are wondering about, and of course, Dr. Patino in his office answers them. And this evening, we're going to chat about antidepressants, in particular, the myths and realities associated with it, because we hear a lot of things anecdotally, negative aspects of it. But the reality is, Doctor, even though you've mentioned in the past that this is an old concept, a lot of these medications really do work.
Yeah, you see, antidepressants are some of the most misunderstood medications in medicine in general. And there's a lot of myth and a lot of um, misinformation about it. But I think in part is because we, for a long time, tried to sell the idea that antidepressants fix things, right? And I think that if we start with that process, we start understanding that antidepressants are not the treatment of depression, they're the treatment of the symptoms associated with depression. And that's terribly important because people forget that depression is a complex illness that involves biology, psychology, sociology, social interactions, personality, and so on. So back in the 1980s, when I was in training for psychiatry, we used to not have what you have today. Today you have the Prozacs and the Cymbaltas and the Lexapros and the Zoloft and the Paxils and the Wellbutrin, a huge number of different medications that actually come out of a theory that was developed in the 1950s that had to do with the idea that neurotransmitters in the brain had something to do with depression. Right? And up until recently, most of the developments that have come out of uh, antidepressants have come out of that theory that was right now is probably about 75 years old. And that came out by accident because they started finding out that medications that impacted serotonin and norepinephrine and dopamine had an effect on depression, just like medications that affected dopamine and histamine and anticholinergic systems had an effect on psychosis, right? We're not talking about antipsychotics today, but the first antipsychotic, which was chlorpromazine back in the 1950s, was not developed initially as an antipsychotic. But the same thing happens with antidepressants. We learn about it. The problem was that we became so fascinated by the theory and the fact that they did have an effect on the symptoms associated with depression that we didn't expand the theory. It
Mm.
wasn't until the late 1990s when we learned more about the brain that we started looking into more detail at other mechanisms that go beyond serotonin, dopamine, and norepinephrine, right?
Okay, so again, as you see some of the comments coming, and that people are concerned that big pharma, we hear that term all the time, and the medicines themselves are actually causing more illness and dis-ease than they solve. What is your take on that?
Well, I mean, in order for big pharma to be no good, then you have to have no illnesses, right? So if you put it in a balance, big pharma may not have the best economic model, but it's provided us with a lot of guidance in terms of how to treat a multitude of illnesses. So the ones that I know the best are psychiatric medications, right? And I hear some of the comments that medications turn people into zombies and things of that sort. And that is correct to a certain extent because in something that we need to understand in pharmacology in general is that in order for us to provide adequate treatment, we need to provide a balance between efficacy and tolerability. All
Mhm.
right. So efficacy means the positive effects, tolerability means the side effects. And some of these medications, in some people, especially people who are genetically susceptible, are going to have more side effects. So for us as prescribers of these medications, we should be managing the medications in a way that we regulate to efficacy and tolerability. So it becomes very important for most people to understand that this is not religion, this is science. So it's not something that we believe or we like or we dislike, it's something that we have to understand scientifically. And we know today that depression is an illness that impacts your genetics, impacts your adaptation, impacts um, a lot of systems that have to do with your system in general, right? Because now we know that stress in relationship to depression is a very toxic situation for for the body in general. There are very few things that are as toxic to the brain and the rest of the body as stress. And
Hmm.
as society has become more stressed and our need to know immediately, being stressed by that leads to more depression and more mental health problems.
It's interesting. I'm reading some of the comments coming in, and I understand. I've been down that road personally. That eating healthy, taking vitamins is important, and yes, maybe the divine is the ultimate healer. But you've already made that statement that we're not taking these meds to heal anything. We're taking them simply to help manage the side effects that are causing so much pain and dysfunction so that we can actually look at and potentially try to do more for the disease itself. Is that correct?
Well, that's not only correct, but we need to understand that a concept that is kind of alien to most people is the concept of homeostasis. What does that mean? Homeostasis means balance, right? In order for the body to be functional, there's got to be balance of your biological systems, your mental systems, your muscular systems, right? So we're always looking for homeostasis. The same thing happens with psychiatric issues. We're trying to balance things so people can be as content or as miserable as the rest of us
Hmm.
who don't suffer from depression, right? So let me give you some numbers about depression and why antidepressants are important. One of them is the fact that right now depression is the third leading cause of disability in the world.
Wow.
Okay, so and getting closer to second, getting close to cardiac disease, for example, and accidents and things like that. But it's a very disabling illness because having depression, like an illness, it feels like having the flu for a very long time, right? You have no energy, no motivation, no interest. You cannot concentrate. You cannot problem solve. You cannot sleep. So a lot of the symptoms of depression are technically physical symptoms, the same symptoms you get when you get an inflammatory disorder, an autoimmune disorder. Uh, so when we talk about medication in particular, which is what we're talking about now, we're always looking for medications that will reduce the intensity of the symptoms so we can improve the patient's functionality. And I've used this example in the past. Diabetes is not a completely understood illness, and there's no treatment for it that will fix it, right? Once you become seriously ill with either diabetes type 1 or diabetes type 2, which are very different, and you have problems with insulin resistance and things of that sort, and you go to the doctor who gives you insulin or metformin or some of the new GLP-1 medications for diabetes are not the treatment of diabetes.
Hmm.
They're the treatment of high blood sugar, okay, or treatment of metabolic abnormalities. I mean, but if you want to treat diabetes properly, there are going to be patients who can control it with diet. There are people who can control it with exercise. There are people who can control it by having a healthy life, not smoking, not drinking, and so on. But that's the minority of the people, right? Not that is not possible. The same thing happens with depression. If the depression is not very disabling, it's actually self-limited, and people might be able to manage it. So when do we recommend insulin for diabetes or antidepressants for depression? Is when the individual has become very dysfunctional, right? So at the end of the day, we don't cure depression and we don't cure diabetes, but we may facilitate the functionality of the individual so they can lead their lives more adaptively, right?
So, question: how you mentioned before that some of these medications came from concepts and theories in the 1950s, but you also mentioned that some of these meds, maybe this was before the show, were actually they actually accidentally found that they affected these things. So, what is the process of them discovering these substances that then can be used as medications, and then what's the process of a medication being tested and approved so that it can be out for general use?
Well, things have changed a lot over the last 100 years, right? There was a time when they were, for example, looking for antihistaminics or anesthetics or tranquilizers, and they found that they have other effects.
Hmm.
Um, so we need to understand that to understand the biology of psychiatry, which is fairly recent, we have to look at the whole movie. And it was, I don't know, 120, 140 years ago that we were not talking about medications. We were talking about psychoanalysis, right? And then things eventually changed. We didn't have enough medications. Patients with epilepsy were in the state hospital. And then we have issues related to um, the learning and starting to develop medications, and a lot of them were developed by accident. Eventually, though, once you get into the late 1970s, 1980s, during what we call the biological revolution of psychiatry, we started to believe that we found answers, right? That now we know more about the brain. Now we can get more into molecular biology. Now we can get more into computers and analyze models and design molecules. And then you get into medications like Celexa, Prozac, and those kinds of medications. Unfortunately, during that time, I would say 1980, 1980 to let's say 2000, there was a big push for medications. I mean, and I think it was so intense that we got lost with the idea that medications fix things, right?
Hmm.
Um, until we learn that the medications do not fix things, they don't have the impact in the brain at the level of the brain required that needs to move into other areas of the brain. And what we learn is that the models that were being used were useful in terms of reducing intensity of symptoms. But there's about 30% of people who don't respond to the medications, and there's a good number of those who respond that have severe side effects. You know, anhedonia, decreased sex drive, difficulty with diarrhea and vomiting. I mean, so some of them will sleep too much, become very indifferent. So there's a universe of people that become very functional, people who cannot tolerate the medications, and then we have people who just don't respond, right?
Hmm.
So as they started looking more and more and more detail into this, they started to learn that there are other levels of the brain where there is more of an impact in longer term results. So, for example, we're working right now on a isomer of methadone research project. We're looking at some precursors of psilocybin in terms of looking at the possibility of those being of some help. And there's been a lot of anecdotal evidence on ketamine and psilocybin, but there hasn't been a lot of placebo controlled studies because for a medication to be effective, it has to be statistically better than sugar pills, right?
Hmm.
So it's significantly better, otherwise, it will not be approved. But then we have to get back to the basics, and is that the treatment of depression is not medications. Medications reduce the intensity of symptoms, but patients have to learn through counseling, therapy, uh, church, how to cope with life in less destructive ways, and then how they can improve the social environment. So again, it's a more cohesive way of looking at this.
Okay, well, since I've been obviously working with you and exposed to you, I've very much understood that again, these medications just help manage symptoms. However, you were just talking about some of the new potential alternatives, the ketamines, the psilocybins, I mean, even other hallucinogenics, MDMA. I have heard, and as you said, we talked about this before the show. There doesn't seem to be a lot of science, quote unquote, behind it in the sense of no placebo, double-blind studies. However, a lot of the claims we're hearing about these new drugs, or in particular the hallucinogenics, or and the like, are they actually say they are curing people? Is that even possible?
Well, cure is a very high bar. Uh, and I mentioned this before because my father was also a physician and he used to tell me if you don't kill it with antibiotics or uh, uh, cut it by surgery, we don't cure anything, right? But because we need to move away from the idea that we want to cure things, right? And there's actually, you can see some tendency on, for example, cancer treatment, moving away from uh, cutting things and try to kill the cancer, right? Versus can the person live with cancer for as long as they would have lived otherwise, right?
Hmm.
So can we look at cancer management as a long-term treatment? So the same thing happens with psychiatric treatment, but that requires a multitude of interventions, right? Biological, psychological, and social. So I don't think that we have any substance in psychiatry that cures anything, right? Why is that? Because the principle of what we're treating is not final, right? We haven't arrived to a point where we can say that we have found all the answers, right? So it's a work in progress. So that's why I keep coming back to the idea that this is not about fixing things. This is not about curing things. This is about helping people live their lives functionally with as little symptoms as possible or no symptoms as possible. So let's say that I'm so successful with a combination of medication or one medication and the patient has no symptoms. That's great. But I can't say that they won't have depression again, right? So we have to look at this globally and move away from the idea that we're treating an illness and understand that we're treating a human being. We're treating a person that deserves to be functional by whatever means, whether the means are, I mean, I have, because I work with kids all the time, and all the time there's kids that come with severe depression and suicidal ideation, and they're in the hospital. And I never tell the parents your kid has to take medications. I may tell the parents your kid could benefit from the medication, but I have to respect when they say no. If the parents say no, I have to look for other options. I have to look for psychological options, religious options, social rehabilitation options, depending on the problem we're treating. But it's important to understand that there's no a direct correlation between taking this pill and being happy.
Well, you've discussed the big pharma concept, where this came from, the testing, but even some the reality that some of these newly um, upcoming psychedelics in particular are really never going to cure anything. But we've discussed this before, and as you know, I've had personal experience with this. I had two friends not make it through their initial search for a functioning um, antidepressant, and that seems to be to a certain extent, and for certain people, a type of Russian roulette, in that someone tries a new med and either the it doesn't work, it increases the issues, or causes those side effects. And we've all read them, and we see them even on things on TV, may cause suicidal thoughts. How is that process being better managed so that someone who needs these in order to help manage those symptoms can survive the process of finding one that works?
Well, there are a number of social issues, and I'm not necessarily here to criticize big pharma because I think that big pharma, in general, in medicine, not just in psychiatry, has given us a lot of tools. Right now, do I agree with the way that big pharma promotes? Do I agree with the way that big pharma pushes medications? to the public directly, that is very controversial. You know, you seeing an advertisement of a medication, and the patient comes to my office and I say, I saw that this medication is great. You know, I want to try this. Then I have to work with the individual and then explain and understand the complications associated with the statements that are being made. So there's no way that in 30 seconds you're going to provide anybody with any high degree of confidence, right? So that requires that physicians spend enough time with their patients to discuss the pros and cons. I don't believe that it's our job as physicians or prescribers to tell people what to do. I do believe that it's our job to provide people with options, whether it's medications or not, right? If it is diabetes and the patient don't want insulin, the patient needs to leave the office with the understanding that they can try controlling the blood sugar with a diet and exercise and losing weight, and what the potential risks are that they're taking, right? If you come to the emergency room with appendicitis and the doctor tells you, well, you may not want to have surgery, but these are the risks. If you have surgery, you're going to have to get anesthesia. You can bleed on the table, or you can get an infection, right? Which is the most common side effects of removing your appendix. But if you if you don't get the surgery, there's a high probability that you're going to get a bad infection and you're going to die,
Mhm.
right? But we have to respect the choice of the patient, right? Because that becomes tremendously important, that the patient is the one that makes the decision of what treatment they want.
It's just as I'm listening to you, it comes to mind because again, I had two friends who ended up actually committing suicide in the process of trying to find the meds, and they were both kind of macho guys. And it sounds from what you're saying is on your side, you're providing the options, here are the risks, the benefits, but the patient has a responsibility too. To tell you, hey, this doesn't feel right, something's not working. Am I correct in saying that?
Well, you see, once you embark in the decision and the patient has chosen to take medications, then we have to develop a trust relationship, right? Because the only person I have, I mean, if this are adult patients, the only person I have to trust with the process is the patient, right?
Mm.
So the patient have to take the medication. The patient has to document if it's helping or not helping. Sometimes extended family or close family might be able to provide information about what they're seeing, right? Uh, but it's not about believing. Again, this is not about religion. This is about the objective findings of a trial. You want to try this medication. These are the potential benefits, the potential dangers. Are you willing to do that, right? I do believe that when we don't take that approach is when physicians get in trouble, because they're basically telling people what to do. You become dictatorial. This is what you have to do, and then that's not a healthy, trusting relationship with the patient.
So, what is the greatest challenge from you as a psychiatrist with a patient? Is it compliance? Is it getting that data back? Is it, and as you know, especially older patients, hey, you're my doctor, I'll do whatever you say, and kind of just try to toughen themselves through it. What do you want from a patient as a doctor? Hey, I've prescribed this, and then you're waiting for data back. What are you looking to see, and what are the greatest challenges there?
In medicine in general, and in psychiatry in particular, the biggest challenge is compliance with treatment, right? But not compliance just with taking pills, compliance with not drinking, compliance with not smoking, compliance with following a diet. And it sounds easy, but it's difficult. And then after having poor compliance, you have some degree of deceptiveness, right? You ask the patient, um, have you been taking your medication? Your patient say yes. How do you know the patient is taking the medication, right? So a very long time ago, and because I trained students both in medicine and physician assistants and nurse practitioners, I would say never ask the patient if they take their medications. Ask the patient, how many doses have you missed
Mm.
since the last time we talked, or in the last 30 days, or in the last 10 days, whatever. What do we know statistically? Statistically, we know that 30% of patients that have to take medications chronically, meaning more than 6 months, whether it's for depression or diabetes or hypertension, miss at least 10 doses of their medication per month, right?
Wow, that's a pretty high
Okay.
number.
Yes, and we've known this for a very long time. So it's not only a big number, it's also a lot of waste of medication that is being paid for that nobody. So it goes into the billions of dollars. So non-compliance is a major issue. Second, patients don't, they're not lying to you when they say that they're taking their medications. They're actually pleasing you. Patients want to be liked too. So if it pleases the doctor to hear that I take my medications, I tell them that I take my medications. So we need to train our patients to understand that it pleases you to know when they don't take the medication, when they don't follow the diet, when they're not taking the blood pressure medications. Why is that? Not only because it is a serious issue in terms of not taking the medication, but the physician, if the physician is not exploring that in detail, right? Like, okay, bring me your bottle of medication to see how many you have left, or things of that sort, or asking the patient how many doses you've missed, the physician is going to take an action, right? So the patient coming in, not taking the medication properly, blood pressure is still elevated, but let's increase the dose, or let's add a second medication, right? So all of a sudden, you're making decisions medically on faulty information. That is why it's so important to have a trusting relationship, right? So if a patient is not taking the antidepressant and continues to be depressed, I need to know that, right? If the patient is having side effects, I need to know now, and I need to have a mechanism to trust that. That becomes very, very important.
You mentioned in Europe they're actually trying to do more injectable long-term medications in order to help that compliance. Is it working, one, and do you think that'll ever be something here in the United States?
Well, there is a lot of actually mostly for antipsychotic
Okay.
medications and in patients with schizophrenia. And we talked about schizophrenia last week, so I think it's a good segue into that particular issue. And my experience in the United States is that there's like a needle phobia, right? And it's not. I'm not speaking about patients. I'm talking about physicians. The physicians don't think about long-term injectables as a first choice. And in an illness with schizophrenia, when patients don't start getting the proper treatment until after they've been in the hospital 2 or 3 or 4 times, right? If we were able to get a higher percentage of patients with schizophrenia and electing antipsychotic early in the process, either the first or the second hospitalization, then the possibility of the patient having a longer functional life will be better. Because as we said last week, in patients with schizophrenia, invariably, because they start so young and they're so impulsive, they stop taking the medications after they leave the hospital, start using drugs, get psychotic again, get hospitalized again, and then you go through the same process 3, 4, 5 times. So in Europe and in some Southeast Asia countries, Australia, the use of uh, atypical long-acting antipsychotics in patients with schizophrenia is probably 4, 5, 6 fold higher than here in the United States, and they have much better outcomes.
But there's nothing like that as at this currently for depression.
Not at this point. The closest we can get is a non-FDA approved intervention that we use with ketamine. Ketamine is probably the most studied medication, non-psychiatric medication used in psychiatry because it's been used since the 1990s, uh, and it probably has been very much studied by like National Institute of Mental Health and so on. It's very effective. We're trying to look in more detail about how it works. Uh, but we do see very good responses as being looked at against placebo. But it will never be approved by the FDA for the treatment of depression because of issues that have to do with patents and things of that sort.
Is it possible? Is there anything that you are aware of, maybe in the psychedelics, that could potentially fill that void?
Yes, very early. I think that. part of the problem with psychedelics like mushrooms or psilocybin and those kinds of substances is that they're naturally occurring substances. It's like lithium.
Mm,
Lithium took a very long time to come in the United States because it's a naturally occurring substance, and you cannot have a patent on a naturally occurring substance.
mm,
So, what is happening a lot, not only in the United States but outside of the United States, is research into looking at the substances in the mushroom that may have an effect on facilitating improvement of depressive symptoms, right? So that is very encouraging. There's some companies outside of the United States that are looking at what we call level one research, looking at animal research. There is the methadone side in terms of the isomers of that. There are also some research going on in that side. So there is hope that we're going to get better understanding of depression, right? So people can be more functional. But again, as I said at the beginning, 2/3 of the treatment of depression are not pills.
mm.
Is learning to live with yourself, learning to cope with life in less destructive ways, and learning to live in society without any isolation.
Of course, as you mentioned, the meds are just to help those symptoms so we can get to those other factors. Once again, doctor, thank you very much for your time and information. And everybody out there, like, share, and subscribe. And we'll see you again next week.
Hey, thank you very much. We'll see you next week. Thank you.